Welcome everybody to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for February 10th, 2022. Today's CME activity code is 484714. We've got a great case today by Dr. Gashti and Dr. Schlottman. We'll get started in a second. We have nothing to disclose. We do change the protocol completely for patient anonymity, and we change other values as well, including some laboratory values. So the patient really is absolutely unidentifiable. This is being recorded. It'll be up on YouTube in a few days by our technical genius, Dr. Baxi. I think we can get started. I want to put the protocol up, and Kelly, you want to read it for us? Kelly's one of our first-year fellows.
Okay. The patient is a 67-year-old Hispanic woman who has a past medical history of hypertension, hyperlipidemia, CKD stage 3B, and metastatic endometrial cancer. She does have mets to the lumbar spine. She's being treated with Keytruda or pembrolizumab, which is a PD-1 inhibitor, Lenvima or lenvatinib, which is a tyrosine kinase inhibitor, and Zometa. She was admitted directly from oncology clinic for an elevated serum creatinine of 3.2 milligrams per deciliter on outpatient labs. For reference, her recent creatinine baseline was around 1.3 to 1.6. She has chronic poor appetite. However, for the last week, she has been eating less than normal due to constant nausea. She reports associated lightheadedness for the same time period. She denies urinary frequency, dysuria, hematuria, melena, bright red blood per rectum, diarrhea, fevers, chills, sweats, shortness of breath, chest pain, and NSAID use. Upon admission, she was started on IV fluids without much improvement in her renal function. She was noted to have newly developed electrolyte deficiencies, which we'll go over in a minute. And she required aggressive supplementation. A renal biopsy was performed for evaluation of her AKI on her CKD. Regarding her oncologic history, her cancer was actually diagnosed 4 years ago. She underwent a total abdominal hysterectomy and bilateral salpingo oophorectomy and omentectomy, followed by 6 cycles of carboplatin and Taxol. During this time period, she developed rising creatinine, likely due to platinum-induced nephrotoxicity. Her cancer did progress, so she was transitioned to Avastin monotherapy, Avastin, in other words, bevacizumab, which is a VEGF inhibitor. She received 26 cycles of Avastin over a 2-year period. Eventually, she developed nephrotic range proteinuria, and so she was switched to her current regimen of pembrolizumab, which she received 200 milligrams, and this is a mistake, but she received it about every 21 days, and then Lenvima 10 milligrams daily, and she was switched to this about 1 year ago, prior to her current presentation. Her proteinuria on Avastin peaked at 4.3 grams per gram. Lenvima was dose reduced to 8 milligrams and subsequently 4 milligrams due to poor appetite and nausea and vomiting. Her proteinuria improved after she came off the Avastin, but was elevated at around 3 grams per gram at the time of her current presentation. Her serum creatinine ranged from 1.3 to 1.6, as mentioned above, up to her current presentation. Her past medical history and surgical history includes uterine cancer, uterine fibroids, endometriosis, stage 3 CKD, hypertension, and TAH, BSO, and omentectomy. She was a never smoker, she does not drink, and she has no history or family history of kidney disease. Her medications include Lenvima, 4 milligrams daily, atenolol, 25 milligrams daily, losartan, 25 milligrams daily, amitriptyline, 25 milligrams nightly, Norco, every 6 hours as needed, Tylenol every 6 hours as needed, medical marijuana for appetite stimulation, rosuvastatin 20 milligrams nightly, and then as mentioned, she's now receiving Keytruda infusions as well as monthly Zometa infusions. Her physical exam was remarkable for mild hypertension with blood pressure to 140/80, and she was tachycardic to 112. Her BMI is 21. but otherwise, her physical exam was pretty normal. Her labs are as follows. Her CMP showed a sodium of 138, potassium of 2.5, chloride of 110, bicarb of 13, BUN of 24, creatinine of 3.2, glucose of 108, magnesium of 1.3, and phos of 1.9. Her total protein was 8.4, albumin 3.4, calcium 8.4, total bili was 0.3, alk phos was 134, AST was 26, and ALT was 12. Her ABG showed an acidosis with a pH of 7.18, PCO2 of 38, PO2 of 108, and bicarb of 14. Her CBC had a white count of 8.65 with a normal differential, hemoglobin of 8.7 with an MCV of 87, and platelets of 267. Her LDH was 260, haptoglobin was 377, and SPEP did not show any monoclonal protein. Her UA had a specific gravity of 1.005, pH was 6.5. She did have 1+ protein, 1+ blood, 300 glucose, 5 WBCs, 5 RBCs, and UA was negative for bacteria, ketones, bilirubin, and nitrite. Her UPC was 3.8 grams per gram, and her urine albumin to creatinine ratio was 530 milligrams per gram. UPEP did not show any monoclonal proteins. Renal ultrasound showed that both kidneys were normal in size. Her right kidney was 9.6 centimeters, and her left kidney is 9.6 centimeters. The cortical echogenicity is increased bilaterally. There was no hydronephrosis. However, no visualization of the left, there was no visualization of the left ureteral jet within 5 minutes, which could indicate ureteral obstruction. A percutaneous renal biopsy was performed.
Great. Any questions? Kelly, you get the award for the best audio and a fellow of the year. So whatever you did, the other fellows should use your microphone. Any questions for Dr. Schlotman?
I like how we have a formic acid or a formate reported, an HCO2 of 13. I haven't seen a formate reported before instead of bicarb. I'm just kidding. It's supposed to be HCO3.
Now, Bill, you didn't do that off the top of your head. I guarantee you Googled that before you had the guts to say it, right? Come on, come on.
Of course I Googled it.
Okay, good. Thank you. Formic acid. I didn't know. Great. Dr. Baxi, you want to walk us through your thoughts on this case?
Yeah, this is clearly a case of formate nephropathy, if you haven't heard of it yet, but no, just kidding. So this is it clearly a lot of stuff to kind of digest really. And patient has AKI and that's really what we're main focus is, but there are a lot of other electrolyte issues down there too. But I'll start with the AKI. The first kind of sentence of the case presentation kind of gives us some clue into potential etiologies, and especially when you see these oncology patients, we're on multiple different regimens. So Keytruda, I see Keytruda on there. So checkpoint inhibitors have various lesions, and I'll talk about those. Lenvima. And full Google disclosure, I did quickly look at that up, as I do with many of these oncologic drugs, to see the exact mechanisms of action outside the TK inhibitor. And it seems to be actually part of the class of the vascular endothelial growth factor, and it's a small tyrosine kinase inhibitor. So that plays a role in many different lesions as well. And finally, Zometa, in terms of bisphosphonates, has been shown to also have some lesions. So if you just look at those three, if just from that, I could develop a differential of acute interstitial nephritis that can happen with checkpoint inhibitors. And this can happen anywhere from weeks to months after, especially with the PD-1 inhibitors. There's been some reports of this happening almost a year after. And typically there's a higher risk when patients are on some other medications such as NSAIDs or PPIs, which this patient isn't, but that is another consideration. The checkpoint, the tyrosine kinase inhibitors, whenever I see those, I jump to two major lesions, proteinuria and nephrotic syndrome, as well as TMA. And of course, there are reports of ATN, and I'm sure there are, acute interstitial nephritis that can be seen with those as well. She did have a prior issue with looks like a vascular endothelial growth factor inhibition with proteinuria that was stopped. But there's definitely a potential that this could be also playing a role here. And ultimately, when I come down to the other medications, I don't see anything there. She's on medicinal marijuana, which sure, I don't think that's an issue in this case. It's really the Keytruda and the Zometa. She's, her BMI is quite, only 21. She's tachycardic. She doesn't, a creatinine of 3.2 is quite severe in someone who I suspect has very minimal muscle mass. So, coming to the labs itself, creatinine AKI, she was not eating well. ATN is something I consider, but, again, that's, there's other things here outside of just ATN from, prolonged hypovolemia. So when we get to the labs, that's where it gets, interesting. She has hypokalemia. She has a low bicarb. She has hypomagnesemia and a hypophosphatemia. Now, all of these sometimes we chalk up to nutritional issues sometimes, but I think there's much more here than just poor appetite. And we have some other urine studies that kind of correlate with that. In terms of the bicarb, the bicarb's 13. Her urine pH is high, so she has concerning findings of a distal RTA. And then finally, her glucose is only 108, and she has 300 glucose. So she may have some, also suggests more another proximal lesion. So this is so her electrolytes are quite interesting, and it points to different, really both proximal and maybe even and distal involvement from whatever is going on. And then you look at her UA. Her proteinuria is 3.8 grams, but it's primarily tubular proteinuria because her urine albumin creatinine ratio is only 530. So this all kind of putting everything together really seems like more of a tubular interstitial disease more than a glomerular disease. She has some albuminuria at baseline, but I wouldn't be surprised if she had some, maybe some just segmental scars, some global sclerosis just from her course of prior chemotherapy and just her overall, I guess, medical history and her age as well. Finally, there's also the renal ultrasound, which, there's no visualization of the left ureteral jet, and she has ureteral obstruction. So could her AKI be also in part due to some type of, in terms of obstructive disease, which with some of these patients, if she has metastatic disease, she may have retroperitoneal involvement as well, and that may be causing the AKI. I think ultimately with all the electrolyte abnormalities, I think this is more of a tubular interstitial disease, and I would my number one diagnosis with checkpoint inhibitors would just be acute interstitial nephritis, with plus minus ATN. I don't think she'll have a significant glomerular lesion here in terms of proliferative GN, which can be seen also with these checkpoint inhibitors. She's on the vascular endothelial growth factor inhibition, but again, her proteinuria is primarily tubular. So I think what we're really going to see is acute interstitial nephritis. Other things you can consider, which I don't think is going to be the case here, would be IgA because she's Hispanic. I don't think that's really a consideration here. So it really boils down to interstitial disease here for me. I think the obstruction is just an outlier, and I don't think that is the main cause of her acute rise.
Good. I got to tell you, when I look at this protein creatinine ratio and the albumin creatinine ratio, assuming they were done at the same time, and granted, they're not 100% translatable to a 24-hour urine protein, but even if you're a little bit off, and this is not an overflow proteinuria, at least it's not by the protein electrophoresis. That's got to be one of the highest non-albuminuria, presumably tubular proteinuria I've ever seen, which does support the notion this is a severe tubular interstitial disease. Bill, what are your thoughts?
Yeah, thanks. I mean, when this poor woman, when I think about her case, we're usually thinking about complications of the disease versus complications of therapy, and this seems to be more complications of therapy. And I really like just narrowing it quickly down to what Dr. Baxi did of a tubular interstitial process. I mean, there's a bicarb of 13. We have a serum, a pH of 7.18 and a urine pH of 6.5. That really points towards a significant RTA. I know the anion gap's a little elevated, but there's also some non-gap there too. She has glucoseuria in the setting of euglycemia, which I wasn't sure if Pravir mentioned, but I'm sure he was thinking it. And if we had the urine electrolytes, I don't know this, but I would imagine that she would have a caluresis as well as phosphaturia. So I really like the idea of kind of a both proximal and distal damage and really just massive tubular wasting. And I think the most common etiology of that would be probably the PD-1 checkpoint inhibitor. The timing of that fits. It can be often delayed, just like Pravir said. It could also be vascular disease, which I know some of the TKA inhibitors do that as well. Vascular disease leading to tubular interstitial disease in these findings, but I'm less suspicious of a glomerular disease in this process, in this patient.
I look at that blood gas, and this is not a renal biopsy point, but she's got a respiratory acidosis, and that's clear, or she's uncompensated, no matter what you want to say, inappropriately high PCO2 for that bicarb. And that's kind of a classic description in patients who are hypokalemic from distal RTA. But she's also hypophosphatemic. She's got a lot of reasons to have muscle weakness and not compensate. And just as an aside, I think that's always interesting. Anybody else have any thoughts? Dick, what do you think's going on?
Well, I would have started in this case from the Fanconi syndrome point of view, the differential diagnosis of Fanconi syndrome and AKI in a patient receiving chemotherapy, and which drug is most likely to produce Fanconi syndrome, which is what this patient has.
Well, I would add, that she also has hypomagnesemia, and that's not part of Fanconi syndrome. And if indeed this urine pH is indicative of steady state, that's not really fit a proximal. Doesn't mean she doesn't have a proximal tubular defect, but it also, as Bill implies, that there's a distal tubular acidification defect. So it kind of goes beyond the proximal tubule. Not to say that there's not Fanconi syndrome. I mean, she's got glycosuria and hypophosphatemia. I'm just, we don't have uric acid for fun, do we?
No.
Okay. Anybody else have any thoughts? So Dick, what is your number one etiology here?
Well, I would go along with Dr. Baxi, tubulointerstitial disease secondary to the PD-1 inhibitor.
How does everybody feel? Yeah, I think that's a really good call. How does everybody feel about, if this is interstitial nephritis from a drug with all these tubular defects and this massive tubular proteinuria, only having five white cells. It doesn't change anything in my mind. I'm just kind of shocked that we don't see more pyuria. Does anybody know off the top of your head how strong the association is of pyuria to AIN? Is it not that strong?
Casey may be best to answer that, but while he's going to unmute, I was kind of thinking along the same terms, in that if there's a lot of interstitial nephritis, I think we may think about the PD-1 inhibitor, but what if there's just a lot of chronic tubular interstitial scarring without active nephritis? That might be why there's not as much pyuria. And then you may blame platinum-based therapies more so because they might just cause, almost like an NSAID-related scarring type of tubular interstitial disease as opposed to an active nephritis that we see with the PD-1 inhibitor. So we may be able to kind of narrow it down based on what type of tubular interstitial disease we see. And anecdotally, I've seen rip-roaring interstitial nephritis in the biopsy and not much pyuria at all. We see that classically with transplants a lot. You can see, tubulitis, and then they have 0 white cells in the urine. And so I think we do anecdotally see that quite a bit.
Yeah, thanks, Bill. I think that is a good point. And I'm glad you brought up the cisplatin, because that is a nasty nephrotoxin. And I've seen some really bad persistent tubular defects. This seems to come on quite a long time after that, but I think it's still worth mentioning as a cause of really severe tubulopathy problems. So, but I think pretty much everybody's putting their money on AIN with a checkpoint inhibitor. Any other thoughts?
TMA, TMA again, a renal limited TMA. Some of these, especially because she is on Lenvima, and so some of these renal limited TMAs, you don't see the, her LDH is not that elevated, haptoglobin is high, her bili is fine, her platelets are fine, but sometimes they still have some renal limited TMA that really doesn't show up on our routine lab work and really is only found on the biopsy. We've had a couple cases in at least the onconephrology world with patients who had transplants and transplant-associated TMA, but these medications, sometimes they just cause a little bit of renal limited TMA, and that would cause the AKI. But again, with all the electrolytes and the tubular involvement, I would have to say this is going to be more of a checkpoint initiate induced rather than just TMA from the tyrosine kinase.
And that's a good point. I mean, I don't know, maybe when we get toward the end, Dr. Gashi can tell us, but whether or not it's common to see two lesions. I mean, she's on two nephrotoxic drugs, and do we ever run into these two lesions? We'll get into that, but that if our number one diagnosis is checkpoint inhibitor, that that doesn't rule out the fact that she may have another lesion as well. And I think some of the importance of doing this biopsy is to kind of distinguish what the lesion is, because going forward, the oncology is going to need some information. Oncology is going to need some information on how to go forward. And there are pathways they follow based on what they find and how much of this and how much of that, and whether or not you give steroids or whether you stop the drug permanently, re-challenge, cut the dose. These are all things that are related to these agents, which I think Casey can tell us about later. I think it's time to spin the wheel.
I think while we're spinning, I was kind of thinking also it'd been nice to have a biopsy during the Avastin proteinuria, but obviously they managed that appropriately by just kind of holding it and switching off, and the proteinuria went away. But we would have seen a 67-year-old woman who looks like she had preeclampsia if we biopsied during that time.
Yeah, I think that's a good point, and it's also something that maybe Casey can talk about, and that is, how often should we, if something seems obvious, there's so many new drugs with so many side effects, what is the role of biopsy for these patients, or is it more practical just to cut back or stop or something else? I think there's a lot of questions that we can go over. So the wheel. Chintav.
All right, so this is the trichome stain. We're looking at one core. It looks a pretty good core to me. I don't see a lot of forms in here, but basically we're looking for fibrosis. I see quite a bit of bluish staining area all along the core, like up here, all this stuff right here. And then here also, the tubules are not packed back to back. So obviously there's a lot of interstitial fibrosis. So I would say probably 15 to 20%, less than 25% fibrosis.
Yes, that's exactly what I said, about 20%. Very good. Been well trained.
All right, so
I won't edit that out.
Okay, so this is an H&E stain. I think I don't see any qualms in here. We're basically looking at the tubules. I see a lot of interstitial inflammation, a lot of I think it's pretty predominantly lymphocytic from what I can tell. So a lot of interstitial inflammation. I know we'll look at the tubules better in the PA stain to see how much APN it is, but this has a lot of interstitial inflammation. Basically, one of the differential was interstitial nephritis, and this would definitely point along those lines. I don't know if this cells along this is the indication of tubulitis or something. I'm not sure. Cells.
It looks like that's probably a tubule cut longitudinally. We're seeing a cross section of it there, longitudinal section. Yeah, those are tubular nuclei.
Okay.
But yeah, I agree with you. There's kind of a diffuse interstitial inflammatory infiltrates between the tubules.
Okay.
Yeah, and then we do have one glom up in the top left. Yeah, we started coming up on that one there in the middle, but there's a fuller one up in the top left.
Right here.
Yeah, there you go.
Okay. All right. Yeah, okay. So that looks. I mean, if we look at it, it looks pretty good to me. The capillary look open. Maybe no mesangial expansion or hypercellularity. So yeah, I don't see any glomerular lesion in there.
Yeah, no obvious glaring crescent or any obvious lesion there. Okay, good.
All right. So this is still an H&E stain. No, this is a PS, right? H&E stain. Okay, this is an H&E stain as well. Now we're looking at one glom in the middle of the screen. Looks really good. The capillary loops look open. Maybe some like just mesangial expansion. I wouldn't call hypercellularity because but otherwise there's no crescents. There's no like scarring or anything. So overall, the Bowman's capsule looks good. So overall, a pretty preserved glom with no active lesions in there. Looking around, I see some tubules here. I don't know what this is.
Yeah, so that's some tubular necrosis,
Okay.
that necrotic cellular debris in a tubule that's dilated,
Okay.
distended.
Okay.
Yeah. In fact, to the right of that tubule, you could see some epithelium that's slopped off. See those cells? Yeah, keep going to the right a little bit. Within the lumen. Yeah, there you go. Yeah, see that's tubular necrosis. The epithelium is sloughed off into the lumen. And on the PAS stain, we'll see there's loss of brush border. Yeah. How about the interstitium here? What do you think?
Still see infiltrates, but it was not like as like it's not as much as we saw previously, but you still have a lot of interstitial infiltrate
Yes.
right
Is
here.
Yeah.
Is there any way to identify those cells? I mean, in a very simple sense, are they monocytic? Are they polys? Are they eosinophils? I mean, do you have any thoughts about that?
I know it's predominantly lymphocytic infiltrate, but I'm not entirely sure how to identify it.
Yeah, so I could, yeah, there was a neutrophil there. I can see some occasional polys. We'll see them at higher power, but it looks like it's predominantly mononuclear with some neutrophils mixed in.
Okay.
But no obvious granulomas.
Another H&E stain. This is higher power. So we're looking at like all this tubules that looks. There's a lot of like sloughing off and necrosis there. ATN. Again, a lot of interstitial infiltrates right here.
Yeah. So now you have a good chance to characterize the cells now that we're at a high power.
Right. So yeah, this has like one nucleus. This is like monocytic. Right there.
Yeah, so that there is actually the tubular epithelial cells that's lining the lumen. Yeah. Look at that cluster down there at the bottom. What do you see mostly? What type of cells?
Yeah, let's see here. Mostly monocytic. I don't see
Yeah,
it.
yeah, mostly lymphocytic. Maybe at around 9 o'clock, there's a rare poly. If you up and to the left. Yeah, keep going up. Yeah, you just passed it. Yeah, there it is. Yeah, there's a poly with multiple lobes.
Okay.
So mostly lymphocytic with the occasional polys.
No
I don't see
eosinophils, David?
No eosinophils.
All right, another H&E stain. Again, like tubules look really like this, all sloughed off. Looks pretty damaged tubules here, all this, and then also a lot of interstitial infiltrate. Basically, lymphocytic.
Yeah. So where we are right now, just move the arrow. There's a lumen right there. So that's actually a tubule. There's active tubulitis there. You could make out the lumen. There's an empty space just to the left of the arrow a little bit.
This one
Yeah, keep going to the left a little bit. Yeah, right there. That's what's left of the lumen of that tubule. Otherwise, it's mixed inflammatory cells and tubular epithelium. So that tubule is really being actively destroyed by the infiltrate.
Okay.
You know, it's interesting. It kind of looks like there's some vacuolization too of some of this, and they were severely hypokalemia in this case. Is that right? There's kind of like a bubbly looking to the tubular epithelium.
Yeah. You could see that vacuolization when there's different electrolyte disturbances in the tubules. Yeah.
Bill, I'm really glad you brought that up because I was just about to say that it looks like protein reabsorption droplets, but then I remembered, yeah, that whole hypokalemia lesion that we have, that's been described, and I think that's a good chance that's what it is. That's really really great.
It's
Yep.
seen in IVIG too, but in this case, I mean, I think the K was 2 or something, if I remember.
Yeah, it's 2.5, and I mean, it's a different lesion with IVIG because it's osmotic nephropathy, but I think it's a different pathophysiology, I should say. But yeah, I think for the purposes of teaching, let's just assume that's what it is because that's really a pretty cool thing to see. It's probably nothing, but maybe it is. That's really great.
All right, so another H&E stain. Now we're looking at one glom here. I see it looks pretty good. The capillary loops look open. The mesangium looks good. There's not like hypercellularity or any mesangial expansion here. I don't know, like maybe if you go along this line, maybe I know we look at on EM for the basement membrane, but I feel like this looks a little thin to me, just outlining it. But otherwise, overall, the very preserved glom, no active lesions, no sclerosis, or no crescents.
Okay.
I'm sorry, one more little thing, and I'm sure this is just could you go back there, David? Is we don't often see red cells in Bowman space there, and is that what that is by the tubular
Yeah.
takeoff? I mean,
Yep,
that's
those
kind
are-
of,
those are red cells.
I don't even know why those would be there. We're not anticipating a glomerular lesion here, but that's pretty unusual to see.
Yeah. Yeah, there's one in the tubule at 3 o'clock also. In the tubule at 3 o'clock. Yeah, you're still in the glomerulus. Yeah.
Okay.
Keep going. 3 o'clock. Yeah, and down. There you go. Yeah.
Okay, so this is the Jones stain. We're looking for any holes or spikes, which I don't see any. The loops look good to me. There's no breaks or anything. I don't know what. Let's see.
Yeah. And what about at 6 o'clock? What is oh, it looks like it's messed up.
Those. Oh, this right here.
Yeah.
Oh, is it like the infiltrate, like from the lymphocytes, hilum?
Yeah, that's the hilum of the glomerulus. Yep. Yeah, you could see a major vessel there branching to form 2 capillaries going off. Yep. That's the hilum. Good. Yeah, so I agree with you. I don't see any pathology in the basement membranes, no ruptures or spikes or holes.
Okay, so this is a PAS stain. We have one glom here, which looks pretty good. I don't see any active lesions. The capillary loops look open, no mesangial expansion or hypercellularity. Then we focus more towards the tubules, and I see a lot of ATN tubular necrosis, like this tubule right here. I don't see any brush borders completely. There's no brush borders here or in this one right here. This tubule here, this tubule right here, even this one right here has no brush borders. Then going this way, maybe there's some brush borders here and right here, but mostly there's a lot of ATN in this slide.
Yeah, I agree with you. It's diffuse, a lot of, like you said, lots of brush borders and a lot of tubular debris in the lumens. Good. We do have a little arterial there that looks normal on the near the top left of the screen. So there's no thrombosis or anything. If you go down,
Right,
there it is. Yeah, there's an arterial. Yeah. No thrombi.
Okay, so IgG was negative on immunofluorescence.
Yep, IgG and everything else was negative.
Okay, so now we have an EM here. Just to orient ourselves, this is the blood space, urinary space. So the podocytes, I don't see any effacement of the food processes here, like they look pretty intact. Maybe some focal here or here, but otherwise it looks pretty good. I don't see any deposits here along like subendothelial or any subepithelial deposits. Nothing in the mesangium as well. So there's no deposits on the EM. Basically, like I don't know if this is the basement membrane. If you look at, I know we look for the basement membrane. If there's a little bit of thinning, but I'm sure you measured it, and we'll look at the measurements in next slides or somewhere.
Okay. Yep. Preserved food processes, no deposits.
You know, we're so used to, but we're so used to, glomerular lesions. You're not going to find much better foot processes than that. It's kind of good to see what normal looks like.
Yeah.
So this is another EM blood space, urinary space. We're looking at another, like the food process looks really good here, preserved, no even focal effacement or anything. No deposit here. I don't know what this is right here, but
that's endothelium. You're coming up on an endothelial cell.
okay.
Yeah, because if you go across it over at 9 o'clock, you can see the full cross section of it. Yeah, you got the nucleus and the cytoplasm. So, yeah, you're just coming up on it over there at 2 o'clock.
And nothing in the mesangium. It looks really good. So overall, again, another normal EM. Okay. All right. So the next, so this is another electron microscopy. Blood space, urinary space. Again, the food processes look good here. Maybe some effacement here or here, but nothing out of sorts. So the basement membrane is 409, so which I think it's normal.
Yeah.
Because it's like, yeah, so that's normal. I don't see any, again, no deposits here and no endothelial or subepithelial deposits, nothing in the mesangium. So I don't think there's a thin basement membrane besides normal. All right, so the diagnosis is, I would say severe ATM with acute interstitial nephritis, or the other way around. I saw a lot of ATM, so ATM with AIN.
Yeah.
Great. Chintav, you get an A for reading, you get a C- for your microphone, so we'll have to work on that. Nice read, good case. Anybody have any thoughts about the pathology? Any surprises there?
How much chronicity? Your creatinine was 1316, and I think David, you only said 15 to 20%.
Yeah.
fibrosis,
Yeah,
and
yeah. Because if you look at
almost-
most of those tubules, they're not small and atrophic and scarred. They're good normal size.
Yeah.
Yeah.
So I guess that's good. Creatinine was 1316 before, and so I was expecting a little more chronicity, but I guess that's always a good sign.
Well, I think that's a good point, though. I mean, you think somebody her size with 1.3, if it's really chronic, there could be 50, 60 easily % tubular interstitial fibrosis. So, maybe she's had a lot going on, a little bit going on for a while. I don't remember the protocol well enough to know what truly the baseline was, because she's been on chemo for a while. She got cisplatin for God's sakes. You'd think she'd have a little more disease than that. So at least prognostically.
Yeah, so percentage-wise, David, was it like, it was hard for us to tell because we didn't get to see everything, but was it like 20% was interstitial nephritis and 50% was scar, or was there discrepancy there, or did it really fit that the interstitial nephritis went along with where in the same places where all the scar was?
Well, the interstitial nephritis was diffuse. I mean, early on we saw like a low, medium power. You could see kind of cells infiltrating most of the biopsy, and then the fibrosis. I mean, there was a lot of edema between the two. Yeah, right. If you look at on the PA, kind of have to correlate with the PAS stain and look for the atrophic, irreversibly scarred tubules. It was just, on the mild side, about, as we said, 10 to 20%. Most of these tubules at this point could, regenerate and heal.
Bill, how would you treat her?
Well, all these things with oncology are always tough, and you're also worried about how aggressive the metastatic cancer is, and we often will need to accept end-stage renal disease to make sure that the cancer is away. So there's never a time where we don't discuss with the oncologist and find out what the best approach is. But to me, the pathogenesis of her acute kidney injury really ends up being the checkpoint inhibitor, the PD-1 inhibitor. Now, the data on that isn't, it isn't robust, but there is some data to suggest that you can treat with steroids and give a challenge to steroid, and then even later on re-challenge with the checkpoint inhibitor if needed. And so after discussion with oncology, I would see, can we give this person a chance to have a better renal function by giving her some steroids, counteract the immediate effect of the interstitial nephritis and the checkpoint inhibitor, and then depending on how her cancer progresses, we may need to re-challenge later on. That's how I would probably approach it with them. We didn't really see anything from Avastin, anything from the TK inhibitors necessarily, as far as I know. He said Zometa, we think about FSGS. It was really, I think it's kind of being narrowed down to the PD-1 inhibitor.
What dose would you give her?
I would think I would give her 60 milligrams for at least a month and see. And, make sure that she's also on Bactrim. And I would also try to, I can't remember the rest of her med list, but, make sure that she's not on a PPI, that she's not on anything else that would be obviously causing interstitial nephritis.
Yeah, I'm glad you brought up the PPI, that maybe we can elaborate on that later, or Dr. Gashty can. Well, I'm glad you chose 60 because Dr. Lewis once told us that real nephrologists give 60 milligrams of prednisone for AIN and not 40 milligrams. So
I was going to quote that, but I thought no.
I know when you were smiling, I know that's what you were thinking of, but I thought I thought I would say it anyway because it's an inside joke in the department here. We have a lot of fun with it, but he did say it. Casey, you want to take over?
Yeah, sure.
Yeah,
Can I have a?
Yeah, and I'll give you control. Give me a second here. Go ahead, click on the screen. Yep.
All right. So as you guys saw in the biopsy, it was read as interstitial nephritis and ATN. And so before we did the biopsy, the three major manifestations of this patient was acute kidney injury, the proteinuria, and the electrolyte abnormalities. And we weren't really sure if these were connected or there were different pathophysiologies. She wasn't really on any PPIs. She didn't really have any extra renal manifestations of immunogenicity, like any IDs that would make us sort of pinpoint that this is a checkpoint inhibitor. In those particular cases, a biopsy could be helpful. And I do have a slide that kind of goes over when you actually biopsy and when you just go and give them steroids or withdraw the drug and kind of postpone the biopsy. So just a quick overview of these new targeted cancer therapies that have really flooded the oncology market, and it's really revolutionized cancer therapy, is the idea that a cancer cell would have to essentially do a multiple functions to survive. It has to have certain growth factor receptors for proliferation and growth, and these growth factors will send intracellular signals through various tyrosine kinases, and this leads to proliferation, and through epigenetic regulators. The cancer cells have to promote angiogenesis so they can metastasize. So they have to kind of get close to blood vessels, and they do so by these vascular endothelial growth factor receptors. They have to evade the immune system. So their interaction with the host cells are through what are called checkpoint receptors, and these checkpoint proteins, which include PD-1, PD-L1, and CTLA-4. And also they have to avoid apoptosis. So smart people have sort of found these pathways and have produced molecules to counter these. So we have inhibitors of growth factors, and one of the famous ones is cetuximab, which is notorious for causing hypomagnesemia. Then we have tyrosine kinase inhibitors, which block the intracellular pathway, and those are usually associated with tubular injury, but mostly ATN, not so much interstitial nephritis. Then we have the blockers of vascular endothelial growth factor receptors, and those are VEGF inhibitors such as Avastin or bevacizumab. Those can give you nephrotic syndrome, proteinuria. In fact, this came up in the discussion about proteinuria versus TMA. Proteinuria is by far more common than TMA. A lot of these patients do develop some degree of proteinuria. Usually it's subnephrotic, without hypertension, without edema, without renal insufficiency. And the oncology community, the expert opinion has agreed upon a 2-gram cutoff for proteinuria, where they hold the medicine if the proteinuria goes over, and this is on a 24-hour collection. If the proteinuria goes over 2 grams, they hold the drug. If the patient develops nephrotic syndrome with hypovolemia, hypertension, and edema, that calls for discontinuation of the drug. That is a much more common scenario, is to have some degree of proteinuria, gram and a half. And the pathophysiology is thought to be due to the presence of these VEGF receptors on podocytes. These also are on the endothelial cells, which sort of helps us with understanding the pathophysiology of why they get TMA. If they do develop TMA, obviously the oncologists usually switch them. And then the current patient is actually on checkpoint inhibitors, and there, as I mentioned, there are 3 different groups. And really, this is a very smart way of approaching cancer treatment, is that you basically unleash the immune system so that it recognizes the cancer cell as a non-self and attacks it. Unfortunately, once you rev up the immune system, you can attack self and non-self. And so the idea that autoimmunity can be quote unquote flared, and various organs in the body can undergo some kind of a toxicity from these CPIs is actually rather common. And in fact, it's thought to be a good thing. It signals that the drug is actually working. The immune system is responding. And so hopefully the cancer will be sort of either maintained or improved if the checkpoint inhibitors cause some kind of an itis. In the kidney, acute interstitial nephritis, but other lesions have also been reported. So if you see, for example, pneumonitis, thyroiditis, or dermatitis, that's a side effect and immune adverse event. But for oncologists, that actually is a welcome response. So I have a few bullet points of what are some of the helpful things that as nephrologists we can look at and in these cancer patients who develop AKI while they're on checkpoint inhibitors. The first thing that's important is to remember that it's actually more common for these patients to develop non-immune checkpoint inhibitor-related issues. So 17% of these patients develop some degree of AKI, and it's not related to the checkpoint inhibitors. Only about 2 to 5% are related directly to checkpoint inhibitors. And so pre-renal ATN hemodynamic issues that these patients get can cause AKI. So not every person with a creatinine bump who's on Keytruda is going to have a checkpoint inhibitor-induced problem. Other risk factors include, as many people have mentioned, people who are taking other allergic immune response-inducing drugs like PPIs, NSAIDs, and antibiotics. One of the interesting points about this is that these patients actually have a higher incidence of recovery from their AKI, because discontinuation of the drug plus minus a little bit of glucocorticoids can reverse their creatinine pretty rapidly, as opposed to if it's a ICI just by itself. We have seen an increase in combination use of various checkpoint inhibitors or checkpoint inhibitors with VEGF inhibitor or TKI inhibitors or even conventional chemotherapy. And if you use combination, the risk of AKI increases. So that's something to kind of look out for. The presence of systemic adverse event can be helpful in perhaps confirming your suspicion that the patient is having an allergic reaction and maybe not doing a biopsy. And that's only present in about 43% of these patients. Dr. Baxi mentioned that there's a very variable onset. These patients can have elevation in creatinine a few days after initiation, all the way until months after discontinuation or after the last dose. The most common biopsy finding in these patients is AIN, is over 90%, but there have been reports of post-immune ANCA-negative vasculitis, as well as podocyte injuries, podocytopathy, as well as C3GN. I mentioned that this immune response is desirable. In fact, there have been articles showing that a higher response rate and longer progression-free disease survival in renal cell carcinoma and non-small cell lung cancer. So this is actually a good thing. And stereotherapy is usually very helpful. 80% of patients respond, about 40% would achieve complete remission, 40% will achieve a partial remission. And if you have to reintroduce the checkpoint inhibitor, upon a re-challenge, about 23% of patients will develop a second episode of AKI. So it's definitely in the realm of possibility that if somebody is treated and their creatinine normalizes, that they can reintroduce the checkpoint inhibitor. Obviously, you have to monitor things a little bit better. So there are certain features that would suggest that we should do a kidney biopsy. If the severity of AKI is quite severe, if they're there's no other drug on board, like there is no protonics or they're not taking ibuprofen, and it's just the checkpoint inhibitor, that favors biopsying. If we have other etiologies that cannot be ruled out based on labs, there is no eosinophilia, there's the urine looks clean, something that just doesn't add up. I think a biopsy is or there's maybe too much hematuria. I mean, people are thinking maybe vasculitis. I think those are all the conditions where we favor a biopsy. And so you can kind of see what these things are. And if it's a pretty slam dunk suspicion of, oh, the guy has a rash, his creatinine is up, they just started a checkpoint inhibitor, I think that's, if you feel comfortable on a case-by-case basis, that could potentially favor empiric treatment for presumed checkpoint inhibitor-induced AIN, and you can sort of defer on the biopsy. So there are some features that we can use to decide that. Kind of going back to the electrolyte aspect of this case, electrolyte problems are extremely common in cancer patients. In fact, this is an observational, retrospective study looking back at electrolyte abnormalities in 25,000 patients in China. It's quite a population to look at. And, there's a quarter of these patients will develop hyponatremia, calcium disorders, hypophosphatemia, magnesium abnormalities. And if you look at the breakdown of what kinds of cancers, this is kind of, I suppose, a heat map of what electrolyte abnormalities you get depending on what kind of cancer you have. Leukemias, almost 80% of these patients will have some abnormality, and they include acid base and electrolytes as an abnormality. In our case, our patient had endometrial cancer, and so a quarter of these patients can develop hypophosphatemia and hypokalemia. So this is a very common onconephrology problem that we are advised to weigh in on. So going back to our patient, so she presented with hypokalemia, hypomagnesemia, hypophosphatemia, and a metabolic acidosis. So we got some urine studies, and we did a calculation of fractional excretion of phosphorus, which was 52%. Granted, there are a lot of caveats to using these fractional excretions. This patient is an AKI, where creatinine is 3. We're not talking about a steady state, nor are we talking about a normal GFR. Having said that, she still is wasting quite a bit of phosphorus, and a fractional excretion of potassium was also quite elevated. So the presumption is that there is phos and potassium wasting. And if you look at her urine osmolar gap, as well as her urinary anion gap, they were both the urinary anion gap was positive, suggestive of defect in ammoniogenesis. It was positive 11. And urine osmolar gap was 28, which is rather low. And remember that if we're looking at urine osmolar gap, it represents ammonium salt. So if you have a low urinary osmolar gap, that is suggestive of a renal defect, usually a distal RTA, either type 1 or type 4. And if there's an increase in urine osmolar gap, then you're looking for extra renal, or usually people look at the gut as a source of bicarb loss. So to me, it was really interesting because I couldn't really put together which part of her renal tubule was damaged that gave us this picture. And my conclusion was that every single part of her renal tubule was hit. I mean, she had glycosuria and elevated fractional excretion of phos, which points towards a proximal tubular injury. She had magnesium defect, and granted, she used to get carboplatin many years ago, but she wasn't really that hypomagnesiemic. It seems like the hypomagnesemia was a new problem, and I haven't heard of carboplatin 4 years ago causing hypermagnesemia now. So I have to assume that this is probably due to her ATN/interstitial nephritis, which is due to the checkpoint inhibitor. And with the data that we looked at, the positive urinary anion gap, a low urine osmolar gap, a distal RTA is a diagnosis. So all three parts of her renal tubules were damaged, or at least we had evidence based on her electrolyte abnormalities. And if you look up renal tubular acidosis in checkpoint inhibitors, there are a variety of different case reports, 3 cases here and a variety here and there, with PD-1 inhibitor specifically with Keytruda, which is pembrolizumab. So this is not a new finding, but it's rather rare. So this would obviously be something that we would be interested in writing up, not because this patient had a distal RTA, but because this patient had a pantubulopathy. I mean, this was proximal, middle, and distal tubular acidosis. So going back to those 3 questions that we asked, the AKI, the answer is acute on chronic interstitial nephritis plus ATN. This is what the biopsy helped us with. The cause of the proteinuria, I still believe this was tubular, although it seems like 3 grams was a lot. But to remind you, the urine creatinine was quite low. So this may be an exaggerated a number, but the ratio of albumin to creatinine was 500 and total protein was 3 grams. So there was a disproportionate amount of tubular proteinuria. So I still believe this was tubular in nature, and the fact that the podocytes looked pretty normal and we didn't see any segmental scars sort of supports that. And finally, the cause of the electrolyte abnormalities, I think those are not something that the biopsy necessarily helped us, but the presence of interstitial nephritis and the urine studies kind of helped us narrow down that the pantubulopathy was due to the checkpoint inhibitors. So what we did was we started her on, I'm, I guess, not a real nephrologist. I started her on 40 milligrams of prednisone because
I should have warned you.
Huh?
I should have warned you.
I know, right? This patient's quite frail. And so she was on 40 for about a month, and then we had to drop her down to 20 of prednisone due to some of the side effects she was experiencing. And we basically started loading her up with all these electrolyte supplementation. And we gave her vitamin D for hypocalcemia. We put her on alkali therapy and magnesium and phosphorus and potassium. And so as of 2 days ago, her creatinine is 1.4. So this is from 3. And all her electrolytes are essentially normal. So what we haven't, the next step would be, now that we are tapering her steroids and presumably we have gotten rid of her interstitial nephritis, we want to see if the presence of these electrolyte abnormalities is going to be an ongoing issue, or is this going to go away and we can get her off of all these supplementation. This poor woman has probably less than 1 year prognosis because of her metastases. And for her to go home on a whole bunch of stuff is not really necessarily improving her quality of life. So I would like to get her off of some of these things. So once I get her steroids down, I'm going to start to lower some of these electrolytes replacements and see if we can if she can hold her own. And that's all I have.
Well, that was a wonderful discussion. It will be really interesting to see. I mean, clearly her GFR improved. And as you know, some of these tubular abnormalities from some of the nephrotoxins, for instance, cisplatin and ifosfamide, tenofovir, they don't always get better when you stop the drug to see. But again, I think you have to stop everything and kind of go from there. There are a lot of nice comments about other causes. You mentioned cisplatin, Zometa has been brought up. I mean, there's certainly a lot of things going on. But, you know, the fact of the matter remains, she wasn't doing that badly with her renal function and her electrolytes until she got this drug. So I think it makes a really good case for what you've said. Are there any other comments?
We don't often get to discuss this many electrolytes at a biopsy conference, so I feel like we really went down the path of Bud Rose instead of Heptanstall today, and so it's kind of exciting new change for us. A lot of fun. Thanks, Casey.
Yeah, you know, Bud Rose is many of our heroes, and we miss him deeply. So God bless him.
Great discussion.
Thanks, Dick. I'm going to wrap this up. Thanks everybody for coming. The activity code is 484714. Keep your emails open. We'll send an email. Anybody that saw it today that wasn't on our list, throw us a message. We'll be glad to include you. Tell your friends, and stay safe, and we'll see you next week.